So good afternoon. I would like first to thank the organizers for inviting me today. I will talk about chemotherapy first in resectable liver metastasis in metastatic colorectal patients. So just to say the numbers in Israel, so during 2010 there were 3,400 newly diagnosed colorectal cancer patients, and during the same year we had 1,240 deaths due to the same disease. What's the scope of the problem? So as we all know, 30% of the patients present with synchronous metastasis, and additional 50% will develop metastasis during the years after, leading us to 30 to 35% of the patients have liver-only metastatic disease. We're dividing them into two big groups. The first group, which contains 75 to 80% of the patients, those are the palliative group. They will never be candidate for R0 resection and given palliative chemotherapy. 20 to 25% of the patients are candidate for surgery, either upfront or after neoadjuvant chemotherapy. And those patients, as we know, have cure rate of 10 years cure rate of 20 to 30%, 5 years survival, as was said already before, 40 to 60%. But we have to notice that 70 to 80% will relapse eventually. So most of them have micrometastases that we don't see during the operation. Traditionally, we're dividing those liver-only disease to three groups, as I said, and maybe the latest group is the borderline resectable, which grew during the last few years, and I'll explain very shortly why. And this is, as Professor Urim said, the consensus of the European working group that was published in the Annals of Oncology 2009. In the resectable group, they recommended neoadjuvant combined chemotherapy and after liver resection based on their study that was mentioned already before. Why we oncologists dare to say, give us resectable patient and we will start with chemotherapy or systemic therapy first and only then do a surgery, which is actually the curative treatment. Because for many, many years, the only drug we had was 5-FU. And we used to give it as bolus or in infusion. We used to give it with levamisole or leucovorin, but the results were quite dismal with 5-FU. What happened during the last few years, actually since 2000, we had more chemotherapy options, the irinotecan and the oxaliplatin, usually in combination with 5-FU, and the targeted therapies. From 2004, we're using the bevacizumab, avastin, the cetuximab, and panitumumab. And during the last year, waiting for FDA approval, the regorafenib and the aflibercept. Maybe I will say a few words about each one of them. The aflibercept is actually anti-angiogenic drug, VEGF trap, and for us is doing more or less as avastin, as bevacizumab. The regorafenib is a small molecule multi-tyrosine kinase inhibitor, and for the moment in serving us as third or fourth line for patients which are refractory to any other drug, and we usually give it as single agent, not in combination with chemotherapy. So as we can see, we have multiple agents now that cause the big change in oncology. First of all, we can create doublets of chemotherapy, two drugs together, usually the FOLFOX or the FOLFIRI. Usually in metastatic colon, we don't use the FOLFOXIRI, which is 3 drugs together. And each one of these combinations is combined with targeted therapy or biological therapy, making the combination very effective. So, as Professor Urim said already before, the preoperative treatment advantages, and this is true for most tumors in oncology, not specific for liver metastases, is to enhance resectability. To assess response in tumor, we have chemosensitivity test in a specific patient. We can treat micrometastasis early because, as I showed you, most of the patients have additional metastasis that we are not aware of. And most patients, when they receive the treatment before the operation, have better tolerance to the treatment than in the post-operative setting. So as I said, 2 chemotherapy together, FOLFOX or FOLFIRI, leading us to high response rate of 40 to 50%. In the borderline or conversion therapy, they're leading us to a secondary resection rate, which is very nice. We usually choose oncologists the FOLFOX regimen because it's better established in this setup. It has better toxicity profile for the liver than the FOLFIRI, and it has more clinical data in this setting. As I said again, these drugs that we're treating now in metastatic colorectal patient, chemotherapy, and later on the biological agent, the Avastin, and the cetuximab and the panitumumab, led us to better and better overall survival, and we are in recent trial even passing the 2 years due to systemic therapy only, no relation to surgery. But still, this is not smart enough. We are not personalized enough. And we in oncology are now trying to develop biomarkers. The biomarkers is a very strong tool which allowing us to choose the right treatment for the right patient. And we're actually using them quite often, the HER2 to select patient for Herceptin, the c-KIT for select patient for imatinib, Gleevec, EGFR mutation, which very few patients have, but once you have it, the response to gefitinib and erlotinib in metastatic lung cancer is excellent, and the KRAS mutation, which serving us in metastatic colorectal patient to select the patient for panitumumab or cetuximab. And just recently, during the last year, 2 new biomarkers we are using: the ALK mutation in lung cancer for select the patient to treatment with crizotinib, and the BRAF mutation select patient for vemurafenib. So as we know about the KRAS mutation, we know that it helps us to select the right patient for treatment for anti-EGFR. We know that 40%, maybe not the right patient for treatment, but the right patient not to receive treatment, because 40% of the patient have KRAS mutation. It's usually in codon 12 or 13, and those patients have constantly activating the KRAS signaling, although the receptor in the outer surface of the cell is blocked by cetuximab, the c-KIT is activating, and those patients have no benefit from treatment with those drugs. But here we can see the cell. This is the area where cetuximab and panitumumab works, and we discovered that the KRAS, once it's mutated, activating the downstream cascade, and actually there's no point on this blockage, but we can see that the KRAS is not the only important partner in this cascade. We have many more: the NRAS, the BRAF, the P10, and many more, the amount of the ligand. All those are on their way to serve us as biomarkers to select patient more specifically for a specific treatment. So we can see something that was a study that was published in 2010, 650 chemorefractory patients treated with cetuximab plus chemotherapy, and we can see without selection 24% is the response rate. But once we're choosing or eliminating patient by their biomarker, specific biomarker picture, we can reach even 50% response rate with the use of biomarker only and the same treatment. Since we're talking about neoadjuvant chemotherapy or systemic therapy, we usually put the response rate in a very high place. So we have here the summary of response rate of chemotherapy with anti-EGFR, either cetuximab or panitumumab. And if we're focusing on phase 3 studies, we can see that the response rate is as high as 60%. If we're looking on phase 2 studies that are for liver-limited disease only, and we know now that liver-limited disease responding better to chemotherapy, we can reach response rate that is high as 70%. What about combination with bevacizumab, Avastin? Again, the same chemotherapy combined with Avastin. Phase 3 study, almost 50%. Phase 3 study, 60%. And if we go into phase 2 study, liver-only disease, again, around 70% response rate. So both drugs are quite convincing in combination with chemotherapy. So if I'll summarize the biological part, I would say that bevacizumab, cetuximab, or panitumumab, I don't know to say which one is better, because we have no data from head-to-head comparison. I have no biomarker yet for a VEGF targeted therapy, so Avastin is for all patients. In mutated KRAS, I can say that bevacizumab Avastin is the chosen agent. We should remember to discontinue the biological, not the chemo, 6 to 8 weeks before surgery. And by the MD Anderson theory, we know that it was found to be safe and does not interfere with liver regeneration. So this is the USTC study that Professor Yorin was showing you before. 360 patients were randomized between two arms, surgery only, and neoadjuvant FOLFOX. All patients were resectable, less than 4 liver metastases, and the primary endpoint was progression-free survival. It was published in The Lancet in 2008, and we can see that as far as the response rate, 40% had partial response, third had stable disease, and 6% progressed, relatively a small number. And if we're looking at the primary endpoint of the study, which was disease-free progression after 3 years, if we're looking at the resected group, so we see difference of 9%, that was statistically significant. 33 were disease-free in the surgery group, whereas 42% were disease-free in the neoadjuvant chemotherapy group. And we just heard the overall survival data, which is not a difference. There is no difference between the two groups, overall survival. So if I summarize this part, I will say that use of chemotherapy appear to enhance outcome, improve progression-free survival achieved with surgery. Progressing patients represent bad prognostic group with 5-year survival of 8% only, and maybe we should take into account this group and maybe not to operate them. No comparison was done between perioperative chemotherapy to postoperative, so I don't really know to say which one is better. As I said, we can divide the patient into different prognostic groups depending on their response to the neoadjuvant chemotherapy. So we see that responding patients have less hepatic relapse than patients that had progressive disease and was still resectable. And if we will divide the group for overall survival, we can see that for 5 years overall survival, we have 37% in the partial response group, whereas only 8%, as I said before, were alive after 5 years if they progressed during neoadjuvant chemotherapy. Again, it's serving as prognostic tool and maybe as a tool to recognize patient that does not need surgery, will not have any benefit from surgery. What about adjuvant chemotherapy? So this is a few studies were done trying to answer either as systemic chemotherapy or intraarterial chemotherapy, and to give us an answer if surgery versus surgery only. We don't have one study which is statistically significant. I have to be honest and say that the accrual to those studies was quite poor, saying that most physicians do believe in systemic chemotherapy for their patient and didn't want to refer them for studies maybe that one of the arm containing surgery only. So I'll summarize that preoperative chemotherapy allows recognition of separate prognostic group, as I showed you. We do need to limit the duration of the preoperative therapy to 2 to 3 months to minimize hepatotoxicity. The role of biologic is evolving, but it looks quite promising. Increased use of molecular biomarkers improve treatment outcome by appropriate patient selection, either by if they are patient-based or tumor-based as the KRAS, and many more to come. And of course, if we're taking a patient which is candidate for surgery, we need multidisciplinary team approach to manage those patients. So, thank you.